My name is Dr. Cath Aldridge. I am 43 years old. I have been a consultant radiologist for 15 years, and on a Thursday afternoon in July, I was reviewing a chest CT scan on my second monitor when I felt, with a certainty I could not immediately explain, that I had seen this image before. Not this patient. I had never seen this patient before. Colin Farrow, 58 years old, referred by his GP following 6 weeks of a persistent dry cough. The referral was routine. The scan had been performed that morning. I was the reporting radiologist. But the image on my screen felt familiar in a way that made me stop. I am not a person who trusts feelings in clinical work. I trust evidence. I trust methodology. I trust the systematic process of reading a scan, anatomical region by anatomical region, structure by structure, density by density, that 15 years of practice has made so habitual that it runs beneath conscious thought. What I call a feeling in this context is not intuition in the mystical sense, it is pattern recognition operating faster than I can articulate the pattern. What my pattern recognition was telling me on a Thursday afternoon in July was that the opacity I was looking at in the right lower lobe of Colin Farrow's lung was not new to me. I finished reporting his scan. I noted the opacity. I recommended follow-up imaging in 6 weeks given the clinical context, which was the appropriate response to what I was looking at. Then I closed the file, and I went to find the image I was remembering.
Let me tell you what I found, because the finding took 4 hours, and the 4 hours matter. I have a habit, not a formal system, not something my department has ever required of me, of keeping brief personal notes on scans that have caught my attention. Not clinical notes, those go in the system. These are my notes, a small index maintained in a notebook I have kept for 12 years that records my own observations about images that have stayed with me, not because they were alarming, because they were interesting, because radiological work is full of images that are interesting, and the interesting ones deserve to be remembered, and the notebook is how I remember them. In March, I had written, right lower lobe opacity, unusual distribution, crescent margin, contrast behavior atypical, referred for follow-up, origin unclear, female, 61, respiratory referral, March 14. No name in the notebook. The notebook carries findings and dates, not identifiers. I had learned early that keeping personal clinical notes with patient names raises questions I did not want to have to answer. When I needed the name, I pulled it from the system.
In July, I found the March entry. I went to the archive and searched by date, by referral type, by imaging parameters I had noted. I found her in 4 minutes. I pulled the scan. I put it on the screen beside Colin Farrow's scan, and I sat with both of them for a long time. The opacities were not identical. They were in the same anatomical location, but the patients were different people, with different physiologies and different imaging histories. They were not identical, but they shared a quality, a particular distribution, a specific margin characteristic, a behavior under contrast that I had noted as atypical in March and was now looking at again in July and finding atypical in exactly the same way. 2 patients, 4 months apart, never referred to each other, never connected by any clinical pathway I had access to, both presenting with opacities in the right lower lobe with this specific characteristic. I noted this in my notebook. And then I remembered January.
January had been Martin Quill, 53 years old, referred for a CT following a workplace health assessment that had flagged a concern. I had reported the scan in January and had recommended a 6-week follow-up, which he had attended. The follow-up had shown the opacity was stable and the clinical picture had not progressed. The case had been discharged. I had not written Martin Quill in my notebook in January, but I had thought about his scan, briefly, in March, when I had been writing the June Bright note. I had thought, there was another one recently that had something similar. I had not acted on that thought. I had been busy. March had been a heavy month, and the thought had not been sufficiently crystallized to warrant action. In July, with Colin Farrow and June Bright on my screens, and the pattern becoming impossible to dismiss, I went to January. I pulled Martin Quill's scan. I put it beside the other two. 3 scans, 3 patients. January, March, July. Right lower lobe opacity, crescent margin, atypical contrast behavior. The same quality. The same specific characteristic that I had been unable to name precisely in January, had named as atypical in March, and was now sitting with in July as something that was not disease. Because no disease produces this finding in 3 unconnected patients in this specific way. What produces this finding in 3 unconnected patients is something in the imaging process itself.
The object at the center of everything was a contrast agent batch number. Not a scan, not an opacity, a number printed on the documentation of every imaging procedure performed at the hospital's imaging center, a number that identified the specific batch of intravenous contrast agent used in each CT examination. I pulled the procedural documentation for all 3 scans. Martin Quill, January, batch 7741C. June Bright, March, batch 7741C. Colin Farrow, July, batch 7741C. The same batch. A batch delivered to the imaging center in December of the previous year and distributed across procedures over the following months, as batches are. 3 patients, 3 scans, 7 months apart. The same batch number. The anomaly was not in the patients. The right lower lobe is a gravity-dependent region. When a patient is supine in the scanner, as all CT patients are, contrast agent pools preferentially in dependent lung tissue. A batch with an abnormal viscosity or precipitation characteristic would be most likely to produce a visible artifact in exactly that location, because that is where the agent dwells longest before clearing. The same lobe, 3 patients, the same reason. The anomaly was in the contrast agent. I sat at my desk for a long time after I understood this. Then I went to find Professor Jim Straw. Professor Straw was the head of my department. He had been in the role for 9 years, and he had the particular quality of someone who has heard a great many things from his team and has learned to distinguish quickly between the things that require careful attention and the things that required immediate action. What I told him required both. I told him the 3 patients, the 3 batch numbers, the characteristic, what I believed the finding indicated, not contamination in the toxic sense, but a formulation irregularity in the batch that was producing an artifactual finding in a specific subset of patients, a finding that looked, on initial review, like a pathological opacity, and that had in all 3 cases been reported as warranting follow-up. I told him this clearly and without qualification because I was certain of it, and because the alternative, that I was wrong and there were 3 patients with a genuinely unusual but coincidental presentation, was a hypothesis I had been systematically eliminating for 4 hours. He listened. He asked 3 questions. I answered them. He asked a 4th. I answered that too. Then he picked up the phone. I want to pause here, because the moment Professor Straw picked up the phone was the moment this story left my hands and entered a much larger process, a process that was necessary and correct, and that I had no ability to manage once it was in motion. I had spent 4 hours finding something. I had spent 15 minutes telling someone who could act on it, and then it was moving without me. If you have ever found something that needed to be handed on and felt the particular helplessness of handing it on and waiting, drop a comment below. And subscribe right now, because what the investigation found when it pulled the full distribution record for batch 7741-C is the part that stayed with me. The investigation. The Medicines and Healthcare Products Regulatory Agency was notified within 24 hours. The batch was recalled. The imaging center's records were audited to identify every patient who had received contrast from batch 7741-C over the 7 months it had been in distribution. The number was 23. 23 patients had undergone CT imaging using that batch. Of those 23, 17 had been reported as normal. The formulation irregularity had not produced the artifactual finding in every case, only in a subset where the specific imaging parameters had aligned in a particular way. 6, including my 3, had been reported with the opacity and had been recommended for follow-up imaging. The 7th had been recommended for a biopsy. When the investigation team reviewed the 7th patient's case, a woman named Rosalind Kemp, 64 years old, who had been referred by her GP following a chest infection, they found that she had undergone the biopsy 2 months earlier. The biopsy had been performed by a thoracic surgeon who had been acting on a report that had been produced in good faith by a radiologist who had been reading accurately what they saw on the screen, and what they had seen on the screen had been real and had been an artifact and had not been disease. Rosalind Kemp's biopsy results had come back clear. She had been told she was fine. She did not know, until the investigation reached her, that the reason she needed the biopsy had been a contaminated batch of contrast agent rather than a genuine clinical finding.
Harriet Caine. She was the pharmaceutical investigation lead assigned to the case. She came to the hospital 6 days after the recall to interview the radiology team and to review the chain of events. She was thorough and she was direct, and she spoke to me for 90 minutes on a Monday afternoon in her careful, methodical way. She asked me to walk her through January, March, and July. I did. She asked me to explain the notebook habit, what it was, how I maintained it, why I had started it 12 years ago. I explained. She asked whether I had shared the notebook or its findings with anyone before going to Professor Straw. I had not. She said, the investigation's preliminary view is that the artifact would not have been identified through standard reporting alone. The individual scans were reported correctly based on what was visible. The connection between them required cross-patient pattern recognition that is not a standard part of a reporting radiologist's workflow. She said, your notebook is the reason this was caught. She said it without drama, as a statement of fact. I said that I had been lucky, that the 3 cases had come across my desk rather than being distributed across different reporting radiologists, which would have made the cross-patient connection much less likely. She said, that's true, but you also kept the notebook. Most people don't.
The 7 patients who had undergone procedures they had not needed. 6 had been rescanned and had the clean results confirmed, and had been informed and had been discharged with appropriate explanation and support. Those 6 conversations had been managed by their clinical teams. I was not part of those conversations. I knew they had happened from the investigation summary I received 4 months after the recall. The 7th was Rosalind Kemp and her biopsy. I thought about Rosalind Kemp for a long time. I had not reported her scan. She had come through a different pathway, a different referral, a different reporting radiologist. The biopsy recommendation was not my report. I had not known about her until the investigation summary landed on my desk. I thought about her anyway. Not with guilt. The finding was real. The report was accurate. The radiologist who had recommended the biopsy had been reading the scan correctly. There was no error. There was a contaminated batch of contrast agent that had been improperly formulated. Rosalind Kemp had had a biopsy she did not need because a batch of contrast agent had been improperly formulated. She had not been harmed in the clinical sense. The biopsy had been performed safely, the results had been clear, her recovery had been uncomplicated. But she had gone through something she should not have had to go through, and I sat with that. Not as a radiologist assessing outcomes, as a person who had spent 4 hours on a Thursday afternoon following a thread that, if I had not followed it, would have meant Rosalind Kemp was the only name in the investigation summary and not the 7th. I carried the number 7 differently from how I carried the number 23. 23 was the investigation's number, 7 was mine.
The notebook. I have kept adding to it since July. Not because the batch recall changed my practice in any formal sense. The department reviewed its protocols and made adjustments, and the imaging center implemented additional batch verification procedures, and those changes are institutional and documented and important. I have kept adding to it because July confirmed something I had believed about the work without being able to prove it. The accumulation matters. Not every scan that stays with you turns into something. Most of them stay with you because they are interesting, and that is the end of it. The notebook is full of entries that have never connected to anything except themselves. Images that caught my attention, and that I noted, and that I carry as part of the texture of 15 years of work. But some of them connect, and the connection is only possible if you have kept them. January, March, July. 3 scans. 1 thread, 1 notebook. Here is what batch 7741-C and a habit I have kept for 12 years taught me. The anomaly is not always in the patient. Radiology trains you to look for disease. That is the job. The image is in front of you. The patient has presented with a clinical question. Your role is to answer it. You look for the thing that is wrong with the person in the scan. But sometimes the thing that is wrong is not in the person. Sometimes it is in the system that produced the image, and the only way to find it is to carry enough images in your memory to notice when the system has put something there that should not be there. Most radiologists report what they see and move on, because the caseload is high and the methodology is systematic, and the system, usually, does not put things there that should not be there. When it does, the person who finds it is the person who has been paying attention across time, not just to the scan in front of them, but to all the scans before it. I kept the notebook, 12 years of a habit no one required of me. Keep the habit no one requires of you. It will find something. Drop a comment and tell me your story. I read every single one. And subscribe. I am here every week with a new story. She noticed the image felt familiar. She went back through 12 years of attention. 7 patients carried a different weight after that.